Hello everyone. My name is Min. I'm the Vice President of Creative Design here at PreMedCC, and today I will start off the meeting by introducing Dr. Rahimi. Dr. Rahimi was born in the kitchen of a refugee camp in Peshawar, Pakistan during the Soviet-Afghan War in the 1980s. His family was displaced from the war. His family was displaced from Afghanistan when the war began. His mother fled Afghanistan on foot with her family through the mountainous terrain. His father fought in the war and helped expel the Soviet Union from Afghanistan. Dr. Rahimi came to the USA as a toddler with his younger sister and his mother as refugees. Growing up, he was on numerous government programs, and after high school, he attended Diablo Valley College and transferred to UCLA and graduated magna cum laude, and then was accepted to UC Davis Medical School. He did a residency in New York where he met his wife. And that's it for his biography. Now moving on to you, Dr. Rahimi.
Well, thank you, Min, very much for that wonderful intro. My name is Jamal Rahimi. I'm an ER physician here in Houston, Texas now. Grew up in California, trained in New York, and now on the Third Coast. So thank you guys for listening to my story, and we're going to talk a little bit about my journey through medicine in general and traversing the system as an immigrant, really. I've prepared a lecture here, and I promise you, if you spend the time to listen to me jabber a little bit, we have some fun, interesting, and gross, bloody cases at the end because you're talking to an ER doctor. So of course, you're going to get some cool stuff at the end. So bear with us, and we're going to have some good cases that we'll go through at the end and kind of give you like a crash course introduction into what we do in emergency medicine. So let's go ahead and start. I believe, here, I'll share my screen, and there we go. Is that good?
We can see it.
Great. So one of my favorite quotes: on the road of life, there are passengers and there are drivers. If you're old enough, you remember this is a Volkswagen commercial as well. So drivers wanted. Let's go ahead and start. We're going to start a little bit about my history here. And I think I got to start it off. There we go. You're going to get a lot of technical difficulties today because I am very not tech savvy. So I was able to find my resident alien card, which is really interesting. So that's me as a young little tyke coming to this country and being accepted. So let's talk a little bit about me. Well, as Vin was saying earlier, originally my family was displaced from Afghanistan during the Soviet invasion of Afghanistan in the late 1970s and early 1980s. And my mother and her family fled on foot to the neighboring country, Pakistan. They had to cross mountains and all this other stuff. It took them a couple weeks, and they were able to land in a refugee camp. I was later born in that refugee camp where my mother, we lived in a kitchen of a broken down house kind of thing. And in the mornings, she would take the cot out and, make breakfast. At night, that's where we slept. So I was born in that kitchen. And thankfully, at some point, we were accepted to come to this country as refugees. My mother, sister, and I came to the USA together. And unfortunately, my mom, as you see her, she never got to see her father again. That would be the last time she got to see him at the age of 21. And believe it or not, here is that picture of myself, my mom, and my sister arriving to San Francisco International Airport in the mid-'80s. And my dad snapped that picture as he was waiting for us to show. So that was the first time I ever kind of touched, I don't want to say I touched foot because I was being held. But yeah, that's us right there. Now, my father fought in the Soviet-Afghan War as a freedom fighter, as a mujahideen, as they call him. He and his younger brother were imprisoned during the war, and his brother was executed, taken out one night, and never returned. My father was lucky enough to escape that prison, and he took up arms and fought in the war for many years. And he actually came to this country before we did. And believe it or not, this is weird to understand in this day and age. I mean, I guess not because it's happening in Ukraine, but my father was allowed to go back to Afghanistan during his summers and fight in the war, and then come back and take classes at junior college. So it's something that doesn't really vibe nowadays of like, how can someone do that? They just go and fight in the war and come back. But that was allowed, and that is what he did. So he would fly back and forth, and he fought in that war, and here he is. And this is the front page of the Contra Costa Times. I'm sure a lot of you guys would know that newspaper. So from the lawns of DVC to the hills of Afghanistan. So DVC is the junior college my father went to, Diablo Valley College. Believe it or not, I went there as well later on in life. And there's my young father with one of his guerrilla troops, his freedom fighters, and so this whole front page spread was about him and how he would go off to war during the summer while other people were working in the mall, Sun Valley Mall. It really, the country really allowed us to move forward in that way, and then like help pay back what we've gotten, definitely. So who am I? On paper, anybody can look good, right? On paper, you can make yourself look anyway. So I went to undergrad at UCLA. I graduated magna cum laude. I was lucky enough to get into some good medical schools, and I chose the best, UC Davis School of Medicine, no offense to any others. I went to residency in New York and North Shore LIJ, one of the best as well. Now, currently, I'm core faculty for HCA Healthcare Kingwood Emergency Medicine Residency Program, as well as Associate Professor of Clinical Science at the University of Houston School of Medicine. But who am I? So back to this, on paper, anybody can look really, really good, and you can really present yourself in any kind of way just based on paper, but who are you really? And that's the question. And so for me, I took a year off out of high school. Like I said, I went to junior college for 3 years afterwards. I ended up transferring to UCLA, took a total of 5 years to graduate college with a year off before, and I took a year off afterwards to travel and to do some teaching. So now I'm here. So the question is this the same person? Is the person on the left the same as the person on the right? And the truth is yes, because you can be all of that. You don't have to be that typical straight A, 4.9 GPA out of high school, prodigy, Doogie Howser, 18-year-old, 22-year-old in medical school kind of thing. That's actually not very typical anymore. So a lot of schools do look for what used to be called, or still kind of called, the non-traditional student, but really non-traditional is more traditional nowadays because more people are taking time off before they jump into something that is so time intensive and and stressful as trying to get through a career in medical school. So let's start really, before we get into the medicine, let's talk a little bit about the immigrant life and what it really takes. So when I came here, our culture is much different than the American culture, and it became a kind of a shock trying to get them both together, as a young kid, and trying to figure out, balance the walk on that fence, or that fine line between the two. I celebrated my very first birthday at the age of 12. We're not very big on birthdays in my culture, but it was a big deal, and I do remember that one. So I did a lot of grocery shopping for my family at the age of 9 and on. That's when I first got my bike, and I was able to ride my bicycle to the local grocery store and pick up food, because my father worked a lot, especially during night times. Because my parents were very adamant that we stay close to our culture, my parents tried to fly us back, every so often, which was, half dozen years or so each time. But I've spent a total of a year out there in Afghanistan and Pakistan visiting my family since I've been living in America. I started my first job at 14. I was in high school, freshman, and I got on my bike and just found a job because I wanted to buy things that my friends had. I wanted clothes that were cool. I wanted shoes that I can buy myself. I wanted to go out to McDonald's and eat with them afterwards, after school, and things like that. So I picked up a job, after school job, and worked there for many, many years just to, help me out in that sense. And I really did know what I had here in America. And I really do mean that, because it is a special country for all the ups and downs. It really is. And it gives the opportunity to someone like me and many like me who need that second or third chance to do something with their life. And this is a country that really allows for that. Here is me a few years apart, and both in Afghanistan, believe it or not. So that's me at the age of 12. First time I ever shot a Kalashnikov AK-47. And then that's me at 25, right before I took a trip before I started medical school. And I knew that I was going to be really, really involved and busy with medical school. So I wanted to retouch with my culture and go back and visit. My father and I went back for a great time. And that's me on a blown up Russian, Soviet tank from the war that we were fortunate enough to escape. I became a citizen. Believe it, here's another interesting thing about the country. Not a lot of countries do, if you're born on their land, do they give you citizenship. I was born in Pakistan and I was there. I was not allowed to be a citizen because I was a refugee. I was not a citizen of any country until the United States gave me citizenship of this as a U.S. citizen at the age of 12. And this is the only country I ever want to be a citizen of. Now, after graduating high school, like I said, I went back to visit for 6 months. And this was right at the later half of the year 2000, so right before 9/11. And I came back about 9 or 10 months before 9/11, and I started junior college. And 9/11 hit while we're in junior college, and it became really, really opened my eyes to the underlying angst, and I don't want to say racism specifically, but uncomfortability of people who don't look like you. And it became very adamant and noticeable, especially that was going on. And it was a sad time to realize, that people that your neighbors and things like that started looking at you a little differently. And it really did open my eyes. But again, it's not something special to the United States of America that people do that. So during my time in junior college is when I realized my worth and what I could do, meaning I was smart. I was able to memorize a lot of stuff. I was good at science. I was good at biology, and it worked out that way. And so I realized that I can do more. And back in those days, we have a very large Afghan community in the Bay Area. And one of the things that a lot of us did, because we're not first generation, we're immigrants, we weren't born here. We graduated high school, and a lot of us went to junior college, and we kind of figured out our lives from there. And I would say 90% or so didn't go on from junior college and, go on to work and do other good things. And I realized, hey, I can go on and go to a university. And so I really applied myself, and that's what I did. And thankfully, I was accepted to several universities, and I decided to go to UCLA. Now, the question I always get as a mentor for pre-med students is, do I have what it takes? Do I have what it takes to become a physician, become a doctor, become a leader in the community? And that's a question you have to ask yourself. So what does it take to get to the pinnacle of education? What does it take to be allowed and entrusted with someone's life in their direst time of needs? What does it take to be that person? Is this what it takes? Because this is what we all think it takes, right? 4.8 high school GPA, an Ivy League college GPA of 4.0, a 525 MCAT, the perfect role model. If you do not fit this mold, you cannot be a doctor. I'm sure a lot of you have heard that. Well, this is who I was. I don't remember my high school GPA. Maybe it was 3.5. I don't know. Junior college for 3 years, did okay. Okay enough to transfer. 5 years to graduate, a year off afterwards. I started medical school at 25. Nothing about that last slide was me. And my entire life, I was told, trying to give you a few years, I really, really worked hard at it, is that's who it took to become a physician, was that perfect on paper person that could do no wrong. So it was very off-putting to not have anybody around me kind of sit me down and say, hey, that's not the case. Like, that's not the case. There are second chances. There are other ways to get through this. And if you really dedicate yourself, you can do it and you can pull yourself through. So I made up my mind that medicine was for me, and I knew what I had to do, and that was get good grades, do well on the exams, start really, really applying myself, because again, this is the highest level of education, the highest pinnacle you can reach of education is getting that MD. It takes dedication and commitment. And here's a fun fact: more than 1 in 4 doctors in the US are born in another country. All right, so that's a big deal. We don't talk about that very often, but immigrants are huge in every aspect of this country, and healthcare being a major aspect of this country. We're talking pharmacists, nurses, techs, doctors, whatever. But it is there for us if we want to spend the time and take it. So let's negate the negatives. Let's dispel some myths and some rumors and some issues that might be on your mind, and definitely were on my mind when I was thinking about going to medical school. So I can't afford it. I hear that quite often. Well, what does that mean? This is not a country where you have to afford it in that sense. I know loans are loans and everybody has this very hang up on loans, but if that is what it takes to get you through medical school, because of course the costs are just asinine nowadays, right? That's what it takes. It doesn't matter. It's a loan. You will become a physician. You will pay that loan off very comfortably, I promise you. So when someone says I can't afford it or it's too expensive, it's not. Yes, it is too expensive. But can you afford it once you finish? Yes, you can. Does the loan system need to be changed and all that? Yes, absolutely. Are they predators? Absolutely. But is this the name of the game you have to play? If you don't have a mother, father, or someone else who's well off enough to pay your way, or you pay your way because you work, there are other ways, and loans are doable. And I will tell you that I put myself through medical school with student loans from UC Davis, from Pell Grants, and from the rest. And I paid off my $250,000 of student loans within 3 years of graduating my residency. So it is doable. You don't have to be that aggressive. You can pay it off as comfortably as you want without ever, basically a monthly payment, and never even have to worry about it. Obviously, you're going to pay a lot more in the back end with interest, but that's the point. You're going to make a lot of money, and this is not the point. Is that you're going to make money. Physicians are in the top 1% of earners in this country. So if you're going to complain that you can't pay this, you can't pay your way through med school, take the loan, and you will be able to pay that loan off. All right. Do not let money be the barrier for you to become a physician.
Just want to add one thing. Unemployment is so low for physicians that the Department of Labor does not keep track of it.
Thank you for that. And just to add to that, I, as an ER doctor, can go to any country in the world really and get a job. How employable are you? That's the question, right? As a physician, your skills transcend language. They transcend boundaries and borders of countries because you have golden hands that can save lives. So you can go and get a job somewhere else. A colleague of mine, just as an aside, we went to residency together, and she got fed up with this country, and she's now in New Zealand. And so you can do a lot of different things. And there aren't many broke doctors, I will tell you. How about this? I've heard this quite a few times. It will take too long. What am I gonna do? It's gonna take 10 years, it's gonna take 15 years. Okay, well, let me tell you a story. This is exactly what I used to tell my mother. She would always put, oh, you should do so, you should be a doctor, you should be this. I said, it's gonna take too long, I could do something else. And my mom once sat me down, and I really absorbed this, and she said, look, in 10 years from now, Jamal, you can still be flipping burgers at Burger King or McDonald's, or you can be educating yourself for 10 years, because that 10 years is going to come up, and you'll find yourself flipping burgers or being a doctor. So it's what you do with that time, not the time itself. Remember that, okay? So if you have, and we all do, because we're all breathing, we have the time and the commitment, we can do this. I don't have the grades. This is something I come across a lot with through my social media. People will reach out to me and ask, like, okay, well, I don't have the grades. I didn't do that well in college, and so medical school is not for me. Well, this is again why this is a great country, because we have opportunities and second and third chances to become a physician. So one thing that is post-bac program, a post-baccalaureate program. So you can take all of your pre-required courses before, let's say you graduated with an English degree, and you're like, well, how am I going to go back and do 4 more years of college to get into medical school? Well, you don't have to. It's a 1.5 to 2 year program, sometimes a year program, and taking your prerequisite courses and then applying from there. So that's another way to do it. Okay, well, I was a biology major, and I didn't do so hot. Well, again, you can take post-bacs and boost that GPA up again and really try to apply. So I don't have the grades shouldn't be a barrier. And piggybacking off of what I just said, I've already graduated. Well, that's great. Did you graduate with a history degree, a biology? It doesn't matter. An English degree, you can go back and do a post-bac program and take the courses and then apply to medical school. So it's in this situation, it's probably a 2-year commitment of classes and things before getting back into, before being accepted to medical school. The post-bac programs, I know UC Davis, when I was leaving, had just started a couple years in their post-bac program, but these programs have, let me get off this before someone has a seizure. These programs have very high success rates to be accepted into medical schools. And so they're really hard to get into nowadays as well, but they're really good if you do get into them, and they're abundant.
Actually, Olivia is now in charge of that program.
What's that?
Do you remember Olivia Campa?
Yes.
She's in charge of that program.
Oh my gosh. Oh, that's great. I got to reach out to her. Yes, yeah, but that was it is a great program. Now, along the way, haters are going to do what they do best, and they're going to hate. All right, it's going to be your friends, it might be your family, it's going to be your competition in your classes, and there are people out there who are professional haters, and they're out to get you. They're out to make you feel less than. And I've pulled a couple of my favorite quotes that were said to me. So medical school is not for you. That was told to me by my college counselor twice at UCLA, the same one. Well, why did she tell me that? I still can't figure it out. It may be because it was the way I was dressed. Maybe it was my, chill California attitude. I don't know. She didn't bother to look that I was a 3.78 GPA. She didn't bother to look that I was graduating magna cum laude. She didn't bother looking to she just told me medical school was not for me. That was within a 5-minute conversation of first meeting her. Why? Why did she say? I don't know. I still don't know. But that's what she told me twice, because I met her again and she told me again, wasting my time. And here's my favorite. You're still here. I thought they would have kicked you out by now. And that was told to me in my 4th year by one of our first, in medical, you have classes your first couple of years and then you go on into the hospital. So one of our professors, who is a family practice doc, who's, I don't know if she's still there, but God love her. She, for some reason, because I was not the regular mold, I was a little loud and rambunctious still as a med student. And so this was it just really caught me off guard. It was probably one of the most evil and vile things that's ever been said to me. And I really, really took it personally, because I have no idea what made her say that or any of that, but that's what she thought of me. But it didn't hold me back, because when she said I was a 4th year, I said, what does that matter? I'm graduating. I've done perfectly well in medical school. This is what you're gonna sometimes encounter, guys. And it's one of those things that you just have to know that there are going to be people along the way that do not want you to succeed. There are going to be more people who do want you to succeed, but the ones that don't want you to succeed might be just a touch louder. All right. And you just have to remember that they're going to be out there and they're going to do what they do best. Oops. So now let's talk about our journey. So the journey to become a physician, right? So here we see this and we see a lot of time again. There's a lot of time here. There's years and oh my gosh, what am I going to do in between these years and all that? Well, again, the time goes whether you do something with it or you don't. You can't stop it. So it's going to happen. It's going to catch up to you. So in high school, why doesn't anybody like me? That's all we're thinking about. We're not thinking about much else out of high school, right? Just trying to make it by, not get beat up, graduate or graduate, make our parents happy. So college, that's where you kind of like, man, I just want to get out into the world now. I'm 21, I'm 22, I'm almost graduating. Why do I have to go back and do 4 more years and then 5 more years and then who knows what, when I can make some money now and I've got loans to pay? Why can't I just be rich? That's what we think about in college. So then you get to medical school, and then definitely I had this several times. I don't think I'm smart enough for this. Okay, I've gotten here. I put in the commitment. I made it. But now I don't know if I made the right decision, because everybody around me is much smarter than I am. Yeah, I was smart in my classes in college, but now I'm with all the other smart people. So that makes me less smart. These are defeatist attitudes, I think, and really, really get us down, because as pre-meds and, you guys, we were working hard, right? And it is defeating when you're not at the top and you feel like that can be defeating, but it shouldn't be, because again, you're fighting and competing with the cream of the crop, and you are that cream of the crop as well. You have to remember that. Residency can be long, anywhere from 3 to 8 years, even longer than 8 years, depending on what you want to do as a career. And that can just really, really, really weigh on you. I was thinking about doing a fellowship afterwards, and I didn't want to, because I wanted to get out there and save lives. And a lot of my friends went out and did fellowships and specialists now, and that's great as well. But I'm very happy with jumping right out of residency into my field. And the best thing about it is I'm a forever student. As a physician, as you guys know, it's medicine. It's always just science. Science evolves. It changes. It's forever changing as we get new evidence, new studies, new research. So we're always changing what we learn. When I was when I was a first year at UC Davis, we were taught everybody gets a PSA at a certain age. Check your PSA, get the prostate biopsy, blah, blah, blah. By the 4th year, it was like, hold off on that. Let's talk about it, the physician and the patient themselves, and let's discuss whether or not we need to do this and chase these levels because we're harming people rather than helping them. So medicine changes that fast. I was in school and then everything changed from first year to fourth year, and that's to be expected. So I love educating myself and re-educating myself and being smart. And I think medicine is one of those things. It isn't not just being a physician, being a nurse, being an NP, being a PA, being a pharmacist. You are a forever student because things are changing all the time. And I think that's great. So you're not stagnant. Your brain is always on, your brain is always working, and that's a good thing. Now, I would like to talk about my trip through emergency medicine, and then we will get to some really cool cases and open it up to questions. I know, thanks for bearing with us. I knew my calling was to save lives, and that's pretty much what I felt I wanted to do, and I will definitely tell you how I got into that. But I did 4 years of medical school, and I did 3 years of residency. ER can be 3 years or 4 years, depending on what program you go to. The breakdown is about 70% are 3-year programs in this country, and about 30% or so are 4-year programs. There are many specialties to go into. You can be a general practitioner like I am and see everything, or you can be a specialist, like you can be special with ultrasound, you can do sports medicine, ICU, international medicine, tropical medicine. I mean, there's a lot of different, disaster medicine, FEMA, cruise ship, Caribbean medicine. There's a lot of things you can do when it comes to emergency medicine because our skills are so ubiquitous in the medical field. Now, another great thing about ER is a great pay with great lifestyle. If you don't mind shift work, ER is a great thing for you. You know, my full time is 12 shifts a month. So that's full time for me. And that's a lot, believe it or not, in the ER. But 12 10-hour shifts, so 120 hours a month is considered full time. And but in between those are night shifts, and you've kind of groggy during the day, so you have to transition. So it's not straight up 12 and then 18 days off. You have some transition days. But overall, for my lifestyle, being with my kids and my family, I've never worked since going into medical school after stopping, regular work. I've never worked a 9 to 5. I don't think I'll ever work a 9 to 5. I love shift work. For me, a Monday is a Christmas, is a holiday, is a Sunday, is the same day every day. So it just doesn't matter what day it is. It's the same day for me. So I can work a Sunday or I can be off, Monday, Tuesday, Wednesday. It really varies, which I really like because life is a little crazy like that right now with 2 toddlers. So I will tell you,
there's a question. Can you work 2 jobs as a physician?
I work 3 now. So yes, you definitely can. I currently I do have 3 jobs, but they're 2 of them are things that I like to do, but they are jobs. And yes, you can work more so I knew somebody when I was a resident, he was an attending, he worked 1 day a week as an ER doctor, and he took the part-time pay of $100,000 a year, and he worked 4 days a month or 5 days a month, and he traveled the rest of the time. So he knew his lifestyle, like his happiness was traveling. So he was okay just to make enough money to travel as 1 day a week. So so there's many opportunities to work more than just your job. Whether you want to or not is a big question after you finish, because you want to enjoy your life a little bit as well and have time to, start your family if you haven't started yet, or enjoy your family if you've been busy, getting through all the hardness. So yes, it's very easy to do more than 1 job as a physician.
I think this person was asking the question, can you work at like one hospital and another hospital? Kind of like the group stuff. Like if you work more than 12 shifts, you get paid more. You don't really need to go find a second job.
Yes. Yeah, that is yes. And I'll give you my example again. I'm credentialed at 4 different hospitals. I work, they're in the same, sister family of hospital system that I work in, but I can work in another city if I want. I can work in another state if I wanted to. You can work more than one place. Yeah, you can. So a physician, it's called privileges, and you get privileges at a hospital. You apply for them once, wherever group you work for. But yes, you can work at more than one hospital at the same time as well. Not many do. And the reason is the hospital systems are different. So it's learning two different systems is a big headache, but totally doable.
And nobody stops you from working more than 12 shifts.
No, there is no
They
work.
beg you for it.
As a resident, you're capped at 80 hours, what is it, a week or so. As an attending, you can work till you drop dead. They don't care. So you can work 24-hour shift if you want, and people do work 24-hour shifts. Same thing in the EMS world. So I'm big on EMS. So like paramedics will work 48-hour shifts. EMTs will work 48-hour shifts. So shift work is one of those things that you knock out a 48-hour shift and you're off for 4 days, kind of thing. So I'll tell you my story about what really solidified my jump into emergency medicine. Was I was in the ICU as a med student, and at this time I was teeter-tottering between being a psychiatrist and being trauma, ER. I really liked ER and trauma and life-saving, but I was really beaten down with medicine a lot during med school. So I kind of was looking for an easier way out, and I don't mean easier, no offense to psychiatry, I don't mean it that way. I think psychiatry is great, but I was looking for something that was a little less intense because I had just been through years of medical school. So I was in the ICU and we're rounding on a patient, and the other ICU team was doing something with their own patient, and their patient crashed and coded. So a code blue was called and everybody rushed to that patient's bedside. Our team also went over there. When we got there, there was a resident, and mind you, I was a third year med student, but there was a resident doing CPR, and I just noticed she wasn't doing CPR very well. The position was off, and I had just finished my ER rotation, like really just like amped up. And so I muscled my way in through all these people, tapped the attending who I'd worked with before on the shoulder. I said, tap me in, coach. I just went, tap me in. And he said, go. And I jumped on that patient's stretcher, jumped on it and started doing CPR. And before the crash guard even came, someone yelled out, "We got pulses back." And then I jumped off, and everybody gives me high five. And I'm like, wait, what happened? And we saved this guy, right? And so the next day I walk by him, and he's doing perfectly fine. And he doesn't know me. I don't know him. And I realized I just saved this guy's life 24 hours ago. And then the next day he's still there, and I walk by him, and again, he's not on my team, not on my service. I have nothing to do with him. I never told him I was one of the people who helped him. And I walk by him again, and his family's there the next day. And they're happy and talking. I'm like, wow, I saved this guy's life. And it's one of those, obviously it wasn't just me, but that realization of I'm giddy over knowing that I did something so major and he has no idea that I did that, really stopped me and made me really think about what I wanted to do as a physician. And ER doctors, we are those silent heroes in that sense, because I tell everybody, and I teach my residents this way, if we do our job right, the patient doesn't know that we saved their life. The patient wakes up in the ICU after the gunshot, after the stabbing, after the heart attack, after the stroke. They don't remember anything about that ER visit. They wake up later in the ICU. They come to the ICU, gets all the letters, all the thanks and the kudos as they deserve as well. But the ER doctors are the silent heroes because we don't get those kudos, nor do we want them. I mean, and I say that personally. And that's what made me become the ER physician, was because I realized that I do this because I can do this with my hands, and I'm capable of doing it, even though people told me I wasn't. And so I don't want the kudos. I don't look for the kudos. I don't, it's one of those things that it is just knowing that you can do that. If someone drops at a grocery store, you want to be the one next to them. I always want to be the one next to somebody who's having a hard medical issue, because I know with my hands, if I can't do something or I could not save them, and maybe this is bravado, no one else could have. And I really mean that. And so I told my mom, I said, Mom, guess what? I want to be an ER doctor. And my mom looked at me and said, "You mean the people who see sore throats?" And I was like, and it was a slap in my face. I was like, wait, what? And I didn't realize what people thought of emergency medicine. And she's like, "Wait, you don't want to be a surgeon? You don't want to be, in Michael, a surgeon is a doctor, is a surgeon. That's pretty much it. And so it took me aback to realize that was the case, and that's what people thought of as emergency medicine. Oh, I have a sore throat, I sprained my ankle. And yes, that is what comes into the emergency room, unfortunately, a lot of times. But the life and death stuff all come in through the emergency room. You don't get to see the surgeon. If you're shot, you see me first. If you're stabbed, you see me first. If you're having a stroke, you see me first. If you're having a heart attack, you see me first. You don't see the cardiologist, the neurologist, the trauma surgeon, the other surgeons. You don't see those people until I have a crack at you and I save your life and stabilize you. Then they get their chance. So that is the big thing that people never realized about emergency medicine, or really caught me there, was I am that stabilizer. If I cannot stabilize them, they do not leave my room. They will likely die. They will not get to the cardiologist. They will not get to the neurosurgeon. So it is a very, very, very huge weight on your shoulders, but a responsibility that you hold very, very highly of yourself, and knowing that this is the gravity of what we're dealing with. So a little bit more about ER physicians. So we are the top one, in the top 1% of socioeconomic status that has a daily interaction with the homeless population. All right, think about that. All right, we can live in $1 million houses, but every single, and personally, I don't. Every single day of my life, I have interactions with homeless patients, with meth addicts, with heroin overdoses, with anything, with bed bugs, with lice, with scabies. But that's okay, because I serve anybody who walks through my door. And so that's the reality of it. On average, ER physicians provide about $120,000 of free medical care per year, right? Again, we see indigent, we see homeless people, we see people who cannot pay their bills. And this is one of the best things about being an ER physician. I do not have to ask you for insurance. If you show up in your time of need, I save you. My team saves you. We don't sit there and say, give me money or let me see your insurance. Other countries do that, believe it or not. It's a crazy world. So that's a benefit of being an ER doctor. I don't have to ask for insurance. I get to treat you first and save you and stabilize you, and then that gets figured out later. For example, internal medicine is number 2. They give about $12,000 of free care a year. So there's a huge, huge divide there, right? But those are your top 2 free providers there. ER physicians are frontline workers for major disasters. COVID definitely has taught us a lot there. ER physicians are the doctor you want when someone yells, "Is there a doctor?" If you're on a plane and someone drops dead and they say, "Is there a doctor?" and then the chiropractor gets up, and then the dentist gets up, and then the gets up, and then okay, well, just take that person's life. And again, no offense, but that's, you want that ER doctor, you want maybe the trauma surgeon, you want somebody, the family medicine doctor, you want somebody who knows a little bit about everything to be able to help you. A specialist, if you got a cardiologist or a neurosurgeon on the plane and the guy drops dead from a heart attack, I don't know how many times a neurosurgeon has done CPR. I don't know if the neurosurgeon, I can't drill a hole in someone's brain and suck out their blood like a neurosurgeon can, right? We all have our roles there. So that's why the ER doctor is a good person to have around. And the person with the coolest stories at the dinner table is definitely the ER doctor. We see a lot, and we pull out a lot of things out of a lot of orifices. I definitely think I've been doing this now, total with residency included, for 10 years, 11 years, coming this June. I will have been an attending for 8 years coming this June, or end of June, sorry. And in that time, I have missed 0 days of work as a physician. These are some of my proud moments. So, excuse me, I get a little teary-eyed when I talk about some of these. So I was in Ground Zero, Long Island in Manhasset, where Hurricane Irene touched down. I was also there in the ER, Ground Zero, when Hurricane Sandy or Superstorm Sandy touched down. We were in the hospital for a few days. I actually let my a bunch of residents stay in my apartment, which was close by, while I was in the ER for a few nights manning. And that was a pretty scary, to see and to watch that kind of stuff come in, especially as a resident, to be like, oh my gosh, these are like real disasters, and you're just waiting, and you don't know, what's going to happen, who's going to show up, how much manpower you have, if the power is going to go out, if there's anything. It's just really, really crazy. And then, of course, Hurricane Harvey. Hurricane Harvey really, it affected me a lot. We were one of the few hospitals in Houston still running, and I was trapped with my staff there. We were there for 5 nights straight, unable to get out, but serving the community. We were taking, choppers, getting body bags. Like it was, we were sharing the same, we were sharing the same bed, switching off shift schedules. And we had 13 people to one bathroom with no lights. And this was physicians and nurses and everybody, like having to use our flashlights to go to the bathroom and shower because we had no electricity in some of the areas of the hospital. And we continue to serve our community quite well during Hurricane Harvey, and very proud of it. And then lastly, of course, COVID's COVID. 2 years now, 2.5 years of COVID pandemic. We started a residency program. I've been teaching residents throughout the COVID pandemic. I've watched a lot of people die. I've said goodbye to a lot of people. I've helped them say goodbye to their loved ones via cell phones. And it has been sad, but it has been one of those things that, again, I'm very proud to have gone through it, and to really have helped a lot of people in these situations, unfortunately with some PTSD on the back end, as you can tell, but I wouldn't change it for the world. Emergency medicine isn't for everyone. I mean, some of you guys might be put off, like, oh my God, I don't want to do that. I don't want to be away from my family. During Harvey, my wife was pregnant and she was stuck at the house, and I was stuck in the hospital for 5 nights. So I couldn't be near my pregnant wife with our first child, so it was a big deal. It weighed a lot on me. But that's what we choose to do. Now, if you want to be if you're like, hey, I hate people, I don't ever want to see a patient, well, be a pathologist. You look at tissue samples. Hey, I like my patients quiet and sleep. Well, be a surgeon. Be an anesthesiologist, put them to bed. I only like babies. Well, be a pediatrician. I only like delivering babies. Well, be an OB. There are many fields. Someone crazy like me likes the craziness of the emergency room, but that doesn't mean everybody does. I definitely know emergency medicine is not for everybody, but there is something for everybody in medicine. And that's the beauty of medicine, is that there is something for everybody. As long as you want to be a physician, you will find a place. If you want to do research, you can be an MD, PhD, and we need you guys, right? Because that's how we get our information, is from the bench researchers. There are so many aspects, so many fields of medicine that you can do any aspect of it, and it's just there, and it's for everybody. So now that I've talked a little bit, I think one thing we'll go through is some cases. Now, I will let you know that some of these cases are quite graphic. So if you don't like graphic stuff, turn it off. But otherwise, if you have questions after the cases, or actually during the cases, you can ask questions as well. That'll probably be a better way to do it. But let's go ahead and begin. So these are some cases that I pulled out. I do a lot of word trauma place. So, I see a lot of gunshots, a lot of stabbings, a lot of accidents in general. Texas is the wild, wild west for sure. So we've had some great cases, and let's start with the first one here. And this one actually came from New York when I was a resident. And this young man, unfortunately, was using a forklift and turned over, and he kind of scalped himself. And so he has a very, very deep laceration to his scalp, just boom, like a guillotine kind of right there. And I use this in a lot of my lectures because there's a certain laceration here, or, that requires a good keen eye to pick up on. So it's called a galeal laceration. And if you don't see it, you're going to miss it. And then if you don't fix this laceration before fixing the flap, they could look like they have a stroke because you lose blood flow to the skull. So where is that galeal lac? There it is. Do you see that little guy? And let me show you again. There. See that white thing? And now you see this little, you'll see this little cut right here. So this is your laceration. So this is your galeal laceration right here. This thing needs to be repaired before you repair the rest of the scalp, or else you will lose blood flow to whatever muscle that that galea feeds, and it can look like you have a stroke permanently. And this guy was 28 years old at the time. So I spent a long time really working on him and getting him put together. But there it is again, that galeal laceration. So really, really want to make sure we catch that. And here we go. Afterwards, he ended up with sutures, we did a bunch of buried sutures, a bunch of on top. And I will give you another story about this. And again, I'm a little unique. I do pride myself on that, but I was a senior, and I was in the critical area of the ER, and my attending, I spent about 30 minutes working on this guy at first, and my attending came in, he said, "You're taking too long." And I told him, I was like, well, this is a young man. Like, this is his face, because it went down to his face. I was like, I want to give him a shot, like and he said, well, you're taking too long. You need to leave. Like, get out of there. And I looked at him and I said, well, after I'm done, you can send me home if I take too long, but I'm going to go back in there and finish my job. And I went back in there, and it took me another 40 minutes. And thankfully he didn't send me home. But it was one of those that I fought for my patient, because that's what you have to do. Even, and no fault of mine. I understand as an attending myself, I understand the pressures of time and, having to be held to these times and get people out. But I don't live that way. I live by my patients. And so I spent the time to make sure he did okay. And I wanted to make sure, and when he came back for the removal, you couldn't tell that he had ever been cut. All right. Now, sometimes we don't close things in the emergency room. Sometimes we want to leave them open because we might be closing an infection. So this is called healing by delayed primary closure. So not everything that's going to, if you cut yourself and it's deep and needs stitches, it might not get stitches immediately because it might be too dirty, the wound might be infected already. Those kind of things might be too long of a wait, as far as not wait in the ER, but you waited too long to come in. So this gentleman was bit by he was trying to break up his dogs. They were fighting, and he took the brunt of it. And you can see there's dog hair in this bite, right? You can see little fibers and things like that. So this guy is not getting closed up now. So this all requires to clean out, wash out, and maybe some lipo. I gave him some lipo. So we cut out some of that fat. There's some fat. He really liked that. The fat globules have no pain fibers. So they don't feel when you cut them out. So I did what we call approximating. So as you see, it's just big old, huge chunks just sutured together, but big openings left. So we leave it that way. He comes back 2 days later. The wound looks good. It doesn't look infected. Then I take these out and close it completely. So that's how we do something like this when there's a dog bite or something else. Now, I do a lot of pediatrics. So I do pediatric and adult emergency medicine. And here's a case that I used to teach for suturing as well. And this young kid, unfortunately, was just crawling around, and a painting fell off the wall and cracked him in the head. And what you're seeing here, this film over him, is numbing medication. So instead of injecting him because he's a child and it hurts, we put this film that has numbing medication on it into his wound, and that hopefully will numb it up. It usually gets most of it, but sometimes with something like this, you have to sedate I had to sedate the child, and I had mom sit there and hold his hand because this was a very complicated laceration repair that required multiple layers. I had to put a lot of buried stitches in before. So here we go again. We're taking the film off. Now you see the depth of it. It's pretty deep. And here's a very close up. It's pretty deep. It goes down to the skull. And so what we did first was a buried suture, or many buried sutures. So here you see it's starting to close, and that's because I buried a bunch of sutures, already 2 layers in there, and it's starting to come together. So again here, before I put any sutures on top, this is what it looks like now. You see like that gaping wound in the beginning, and now this one, it's a big difference. So this makes it much easier to close on top with stitches because I closed several layers already underneath. And this was the end product here. It came together beautifully, and I did not get a picture on when he came back. I'd forgotten to, but I talked to mom quite a bit that day. I mean, he looked great, and no matter what, this is going to leave a scar, guys. So don't think we're God and we can, you know, and even plastic surgeons, you know, if it's anatomy, it's biology. If the cut is deep enough throughout the, you know, the epidermis and the dermis and gets into the sub-Q, you're going to have a scar. Don't let the plastic surgeon lie to you. You're gonna have a scar, all right? It's their job is to minimize the scar, which they're really good at, and do other cool techniques as well. But no matter what, you're gonna have a scar. One thing I've learned in my life is chainsaw always wins. You can't fight the chainsaw. All right. So as you can see here, this guy's not his first rodeo. He's already nubbed one of his fingers, his index finger on his right hand. And he just somehow just barely touched the chainsaw to his to the palm. And you can see on the left, the picture, that little on his ring finger, that white thing right smack dab in the center, that's tendon. So he's got exposed tendon, which we had to repair. And this actually came to, because it was such a nice, clean cut, I was able to repair this. But typically with chainsaws, it's such a mess of just tissue. As you can see, that ring finger, the top of it looks pretty awful, that you end up not being able to do much, and they have to go to the operating room.
He lost his index finger before, right? This is a repeat offender.
It's his pointer finger.
He's a repeat offender.
He is. This is not his first rodeo. And many of my patients, I see them for multiple injuries. Although I'm in Houston, you know, we serve a community that's more rural outside of Houston. So we do see a lot of salt of the earth people, which is really cool because they're pretty strong. So things that we don't really fix in the emergency room, we try to, you know, kick the plastic surgeons, and we know is are like eyelid lacerations with exposed fat. If you look on the left, that exposed fat means this is a deep, deep laceration and should be sent to a plastic surgeon. I fixed this one because a lady wanted me to. Her husband punched her in the face. She wouldn't admit to it, but it was pretty obvious. And she did not want to be transferred and not want any more questions. She said, close it or I'm just going to walk out of here. So I went ahead and closed it. It turned out really beautiful. But it was one of those that it was either close it or just let her walk out. And I wanted to do something. So, you know, I took it upon myself, and we went ahead and closed it, and it turned out wonderfully there. And times when you shouldn't even really try. So here's another table saw, or here is a table saw. So here you see this guy just filleted himself, right? And if you look at that pinky, you can see the shattered bone there as well. And we'll get a better closer. This is a side view of it. And you see the bone here. I'm pointing with you see the bone here. And you see a lot of just tissue, fat, muscle, you know, tendons. It's just a mess, right? This is not something that I'm going to fix. So as an ER physician, I know my limitations. I know what I can do. And more importantly, I know what I cannot do or should not do. And mainly because the patient requires something, you know, someone better than me. And I don't mean better, but someone more specialized than me. A hand surgeon would need to take this one, and a hand surgeon did take this one. So the table saw always wins. Be very, very careful, guys. And here's just another view of it here too. So nice and filleted here, just completely open. So gloves are important when you're working around tools. I mean, they can save a lot. Another one, don't get drunk and, piss off your little Cocker Spaniel, or it might bite you in the eye. So this guy, the reason this is up here is here we have a tear duct injury. So the dog, his own dog, but he was messing with him, bit him right here, and he was bleeding bloody tears. So the fact that he's got all this bloody tears coming down tells me that he's got an injury to his tear duct. And that, again, is something that I know is out of my scope. That needs an ophthalmologist. It needs a facial plastic surgeon. It needs someone higher end than me. So if I can't fix it, you need to go, I need to get you to someone who can. And this gentleman was, thankfully, we had to talk him into, he was really drunk. So we had to talk him into being transferred. He refused it, and he kept telling me to do it. And I would not touch this. It's like, I'm not going to do you any favors here, because this is not going to be doing you a favor. I don't know how to fix the tear duct. So, you need to be transferred. We finally held him long enough to where he kind of sobered up and realized that he needed to be transferred, and he was transferred. Another one, running through the woods with bare feet, not a good idea. This guy stepped on something and took off just chunks out of his big toe. I got the text from the medics beforehand saying, hey, this is what we're coming with. And so not much to do there. Wash it out, cut out the fat, and, kind of a deflated toe. Other times, really, believe it or not, we don't fix tips very much. You're going to get a nub a lot of times unless you need that tip of your finger. So we see a lot of fingertip of what they're called avulsions or fingernail avulsions. This guy got caught in a chain, just a regular chain in his that had a heavy weight connected to it, and just fell off his table, and it caught his finger and took the tip of his finger off on the way down. These things usually will numb them up and give them pain control and send them to follow up for the hand surgeon. Other things we can do is just take some flaps of skin and flap them over if we need to. But oftentimes I like to let the hand surgeon handle these.
Dr. Rahimi, so this is a question somebody asked. Can you prescribe medicine to any patient as an ER doctor? And just talk about how you see them and then transfer care and all that good stuff, admitting and.
Yeah, so yes, the answer is yes. I can prescribe any medication. So the ER physician is one of the few physicians who is trained in procedural sedation. And what that is when you need to be put under, for be on a ventilator that's deep sedation or general sedation. But we use some of the most hardcore medications medicine has to offer. One of them is propofol. Propofol, if you guys remember, Michael Jackson died from propofol because his cardiologist was giving him propofol. And propofol is one of those detriment, one of those medications that you have to be trained and certified to use. And I guarantee you he probably wasn't, because he would not have left Michael Jackson alone with propofol. So we use some of the very scariest medications, just like anesthesiologists. We use a lot of their same medications because that's what we do in the ER. Now, when it comes to medications for the patient, nowadays I like to give fentanyl a lot for pain. And I know there's a lot of people who have very, angst against fentanyl because they hear all about the overdoses and the, with all that fake stuff that's going around. Well, that's true. And I tell them, I'm like, well, we've got the good stuff. We've got the pharmaceutical stuff. And we're not lying to you and telling you it's Vicodin and giving you, 10,000 micrograms of fentanyl. So unfortunately, you're buying things off the street. You might have some bad, outcome. But in the emergency room, we're very trained on giving pain medications, seizure medications, medications to put you to sleep, medications to really put you to sleep. Anxiety medications. We know all about reversals. We have to know all about the reversals. So if you come in overdosed on Xanax, overdosed on Norco, overdosed on carbamazepine, overdosed on Tylenol, for God's sakes, aspirin, we need to know how to reverse those. So the ER doc is trained in everything life-threatening. That's what we're trained in. So we got to know a lot of different things in order to save you in that, quick, few minutes that we have before you die. And so knowing your medications, what you have ready, what you can give is very important. And also knowing how you reverse those, just in case you give somebody too much and you're fighting it on the back end. You have to know how to fix that as well. So you have to know what can happen, the complications and the reversal in case there is some complication for that medication. For example, I worked yesterday, last night. I got off at around 2 a.m. this morning, and we had 2 fentanyl overdoses. One of them was pretty bad. The other one, they both got admitted. One of them's probably going to die soon. Young dude, my age, picked up what he thought was cocaine from a coworker. Was fentanyl, unfortunately. So, that's the world we live in nowadays. So now his family's probably gonna be saying goodbye to him very soon. He's not doing so hot. So it's one of those things that it really scares you, knowing a lot about medicine as well, and knowing what's out there and what people are getting into and how they're lying. Drug dealers are lying to other people, and addiction is a disease. I never fault the person who comes in overdosed. That's not what I'm here for. I'm here to save your life. No questions asked. You know how many swastikas on people's chests I see every day, and I'm doing CPR on them? I don't think they would do CPR on me if it was switched, but that's not what I'm here for. I'm not here to judge them. I'm not here to bring my personal opinions on how shitty some people are into that. I took an oath, and my oath is to save your life. And I will save your life, whether you spit in my face, and I've been called, the most racist of terms. It doesn't matter. You have to have thick skin, and you have to remember why you got into this job, and it is to save lives and not to be it is very hard not to be offended when you're trying to save someone's life and they tell you, stop touching me, Sam, N-word, or F you, Arab this or that. And that happens often enough that it's concerning. But it's one of those that if you grow enough of a thick skin, you understand that there are just some idiots out there, and you're here to save everybody, even the idiots. So there's one more here, and then we can definitely open for some questions. So open fractures are some of my favorite things to do, because they're a lot of times not life and death, but what we call life and limb. You can lose that leg, and you don't want to lose that leg, right? And so we have to do these quickly. And again, you're not going to see if you're waiting for the orthopedist to come down and do this for you, you're going to lose your foot. It's going to be gone. So I'm the one doing this for you. They come in different shapes, different ways. This is one of my favorites. This guy was a jockey, and he got caught between his horse and a brick wall, and it snapped his ankle, his leg in half. And he came in. We had to pull him out of his car, bring him in, cut this off. I looked at it. He had no pulse. His toes are blue, so he's about to lose his foot. I was maybe 2 years in as an attending. I looked him dead in the eyes, and I said, my friend, this is going to hurt. And I said, you better bite down on something. And by the time he said, what? I was pulling on this, and he's screaming, and people are holding him down. There's no time to get an IV. There's no time. We got this boy back in. We ended up choppering him out, and he did fine. He got, obviously lifelong injury, but he had surgery, he got clothes, he has his foot. And so it's one of those that oftentimes you do with what you have, right? And this was one of those times I realized, I think this is for me. This job is for me, because I just looked at dead in the house. This is gonna hurt. But at the end of it, emergency medicine is one of those fields where you cause a lot of pain to people, and they shake your hand and say thank you, because you're helping them. Although you're injecting them and reducing them and fixing their broken bones, you didn't cause those broken bones. You didn't cut them yourself. You didn't push them over to cause a broken, laceration, but you fixed it. The fix was painful, but they shake your hand, and that's the beauty of it. You cause a lot of pain sometimes in that sense, but they will shake your hand and say thank you. And this gentleman definitely came back and said thank you. It was one of those great times to have somebody come back and just tell you how much they appreciate what you did for them. And here again, then some exposed tendon here. This is really honestly not an open fracture, but really nice exposed tendon there. And she did very well. We just closed that one right up. So those are the cases. And just a little, before we go into some questions, the last, words of wisdom. And this is personal, because it really, only you can prevent yourself from success. There are going to be people out there who tell you you can't do it. If you listen to them, then you can't do it. It's you who get to choose who you get to listen to. So don't listen to them. Listen to yourself and tell yourself you can do it, because you can. You have to be your biggest fan. You have to be your biggest supporter. If it's not you, then who? If you don't have confidence in yourself, who else is going to? You have to be your biggest fan. And the biggest thing, keep family and friends close. You tend to get into this medicine and spend 20 hours a day, 17 hours a day studying and in classes, and you lose sight of what reality is, what real life is. And mind you, when you have a bad exam score or something bad happens on a rotation, or you get a bad, grade on something, who are you going to fall to other than your family and your friends? You can go to dark, dark rabbit holes and really, really judge yourself if you don't have that support structure. So support structure is very important. And my support structure is that. So thank you very much. Thanks for listening to me, and I would definitely love some questions.
Well, I have a comment. You definitely did marry up, but that's a whole different subject.
That's 100% true. She's a double master's, an MBA, a master's in public health, a BSN, and the mother of 2, almost 3 children now.
Actually, well, 3, almost 4 children.
That's very true.
This is a question. If an attending chooses to send you home, does that go against your record or status of the hospital, stature at the hospital?
So if an attending, so as a resident, so if you're a med student and an attending sends you home, there's a big deal with something's going on with you. Yeah. If you're a resident, it's gonna be very rare. And knowing this now as an attending, I don't see how that attending would have sent me home. I was the only resident. He's not going to let me go home. He's got an extra hand, right? He's working in the ICU part of the ER. So I think that was more of a threat of a get moving kind of thing. I've never once, as an attending, threatened my residents anyway, especially with sending them home. If I ever were to consider sending one of my residents home, it would have to be some egregious act done by them, or they would have to be in an emotional state that, I can tell that they're not doing well today for some reason, and they should just go home. And maybe, because mindfulness is important, and we learned that through COVID, having a healthy mind is just as important as having a healthy body. So that would probably be a reason I would. I've never had to, and it would not. The hospital would never know about it. This would not get out of the emergency room, out of that little group. So it wouldn't look negatively on anybody other than why you were sent home if you were. I don't recall anybody as a med student being sent home either. I've been kicked out of the operating room as a med student because I broke sterile field. Things like that will happen. You make mistakes here and there, but not like go home, you suck kind of thing. No.
Okay, and another question is, how did you find pre-med opportunities when you were at community college?
So there is no such thing as pre-med opportunities. How's that? What I mean by that is I did what I liked. I was in student government, and I started doing blood drives with the Red Cross, and I was a representative for the school, and I did that for a couple of years. So when I have my mentors, and a couple of them are just applying right now to medical school, I tell them all the time, there is no such thing as this is what you need to do to become a doctor. I was on the admissions committee for UC Davis for 2 years as a student representative. There were things that we looked for that had nothing to do with medicine. And what I mean by that is, were you a member of your community, whatever that was? Did you do blood drives? Did you, help ladies cross the street? Whatever it was, did you do something that was interesting? Did you play an instrument? Like, we're looking for well-rounded people, right? You don't want your doctor to be a tool. You don't want your doctor to be like, I'm the doctor, you're the patient, shut up. Like, that's not how medicine should be. It should be shared responsibility, with the physician saying, this is what I think, and the patient saying, thank you, sir. Thank you, doctor. And this is what I'm going to do with the information you've given me, because this is my body, right? That's shared decision making, and that's how it should be.
Okay, thank you for your answer to that question. And we have
I would just also add too, some people have to work. So even if you have to work, I know somebody that was at community college for 5 years, and for 3 of it was a manager of a Little Caesars. And when he was applying, he mentioned, hey, I managed the budget and managed people and customers and complaints. And he was just able to frame it that way, because some people just don't have the luxury of, being a volunteer, or, like, you need to put a roof over your head.
Correct.
But frame that for what you're trying to do.
And Jim, that's a really good way to put it. So my 1 year off between med school, college and med school, one thing I did was a science camp on weekends. I really like NASA. I'm a NASA nerd. And so I got paid for it because I got to do it with K through 5, on weekends. But it was also really cool because I got to learn a lot of cool NASA stuff, and I got to play with the toys with the kids. So it worked out on so many levels. I put it on my application because it was science related, and it was like this cool stuff and all that other things. And you can go out there and make your pre-med journey what you want. When I interviewed people that were coming into medical school when I was a student, I remember having 2 back-to-back interviews. Okay, I'll give you this example. One was a guy he was from Berkeley. He was like 3.9 GPA, killed the MCAT, all that stuff. So we're sitting down at the little sandwich shop, and I asked him, so what do you want to do as a physician? Like, what kind of physician you want to be? What kind of doctor you want to be? Just thinking, like, he doesn't know yet. I want to be a robo-surgeon. And he goes off on whatever a robo-surgeon is. Don't even know if that's a thing. And he's talking about it, and it's just like so boring. I was like, oh God, like, this guy's a tool. Yeah, sure. He's going to get into whatever, he's going to get into anywhere he wants. He's got the numbers to go into those schools that are looking for that, because that's all they, that's how they keep their numbers. But he wasn't right for UC Davis. I could tell he wasn't right. The very next interview, she was from Harvard. She had better numbers than him, 4.0. And we talked about baking. And I was into baking at the time. I was, I live, your second year, you live on your own, you do what you can. So I was into baking, and we talked about baking for an hour. I pleaded that she come to UC Davis. She went probably to Harvard, probably to Yale. She didn't come to us, but you see the difference. The numbers are there. On paper, they're both pristine. On paper, they're both beautiful candidates. And this is the one equalizer that law school doesn't have, that other schools don't have, is that face-to-face interview. And then you realize this person's not going to be good to patients. They're so just like, it's my way, it's da-da-da-da-da, versus this other one who's like so just jovial, cordial, and like just people person, right? Because that's what medicine really needs. To be a good doctor, you need to be a good communicator. And you don't talk over your patients. And that's the biggest deal. So it really is that on paper, you can look one way, but it's that how you really interact with someone else. And that's the biggest deal there.
So this is one that I think this is from people watching too much TV. Can an emergency doctor do surgeries if necessary?
Well, it depends on what you mean, because technically the answer is yes. What do you mean by surgery? Like, I had a gunshot. Maybe it was a week ago, we had, unfortunately, a couple of gunshots, and we did what's called a clamshell thoracotomy. You guys should Google that, clamshell like clam, thoracotomy, and you'll see the picture if you want to see the image of what that is. I've massaged people's hearts. About 2 months ago, I had my finger in the bullet in the heart of a patient who got shot in the chest. While the trauma surgeon was suturing around my finger, the heart closed, and we had cracked his chest. So it really, I giggle because it depends on what you mean by surgery. So if you're saying, I don't take out gallbladders, right?
You don't do Whipples in the ER.
Exactly. So I'm not a thoracic surgeon. I'm not a general surgeon. I'm not doing your gallbladder. I'm not doing your appendix. I'm not cutting you open in your belly. But if you get shot in your chest, I'm opening your chest for sure. I'm squeezing. I've massaged hearts to keep them alive. You know, like, so we do some of the scariest procedures that medicine has to offer us. I am trained in drilling into someone's brain and sucking out blood like a neurosurgeon. I don't do it because I have a neurosurgeon. Why would I do it? But if I were working in Podunk, you know, somewhere, you know, in the hills somewhere, and there was no neurosurgeon and you're bleeding in your brain, guess who you got? Me. So yes, we do emergency life-saving procedures, I would call them. And they're surgeries, right? But we're not doing what you classically think of surgery in the sense of I'm opening you up and taking your gallbladder out on a Sunday, right? That's not what I'm doing. If I'm opening you up, you're about to die.
It's a critical, yeah. And you don't turn the trauma room into an OR. It's usually you're stabilizing to take him to the OR. Not
yes, if they, as I said earlier, they have to be stable to go to the next step. If they're not stable enough to leave the emergency room trauma bay, they're probably going to die in that trauma bay.
I think we have 2 more questions. Go ahead, Min.
Okay, so another questions that we have is, okay, let me scroll through. How is being an immigrant? Sorry. Okay. How is being immigrant impact you in medical school or residency? Did you feel left out or left behind compared to other students?
Wow, I've actually never had that question. That's interesting. The struggle, I think one of them, a lot of people were generational in medical school, meaning their parents were doctors. I had colleagues in my class whose, you know, parents were PhDs at UC Davis, right? So there's a generational aspect of it where you see that, oh, my father was a doctor, my grandfather was a doctor, I'm a doctor. You know, that's one of the big things I noticed was the struggle was different for me than it was for other people. So talking to them, a lot of people didn't understand I learned English when I was 5 and I did all my grocery shopping for my family when I was 9. And you know, I barely graduated high school because I was just being a dumb goof off. And people don't really, they're like, wait, what? Your father didn't and mother didn't make you go 4.0 from, you know, age of 4 on? Like, no, we were just trying to make it and survive. And we were on welfare for a while, right? And we were on the WIC program, and my mom didn't speak English and she never drove. And so, you know, when things, my dad worked all day and night to support us. So we as a family have to really be a family unit. So that was a big difference than, you know, seeing that generational thing. Another one is is really that, the money, and some people having, you know, that greatness of being able to afford a good life in medical school, right? As when you're taking loans, you're living off those pennies. You're paying for school, and you budget the rest out, and you barely make it here and there. So that was also something that was a little more rough on me than I saw from my friends who didn't have those issues. But I think more than anything else, it was a benefit that I was an immigrant. And I say that because I see my mom in every immigrant grandma's eyes. I see, you know, like when we went to emergency rooms as children, you know, we have to go, is an 8-hour, 12-hour wait, right? To get an x-ray of a knee. It was that's what happens. So we don't go to ERs. We don't go to emergency rooms. Immigrants don't, because they know they're going to wait 12, 14 hours to put them away. Like, who cares? One extra going to poo-poo them, not listen to them because they don't speak English, right? Oh, I don't know what you're saying, whatever. Okay, your knee hurts here, kind of thing. I don't do that. Every Hispanic lady that comes through my ER looks like my mother, and I treat them like my mother. Every person who does not speak English, who comes to my emergency room, I grab the interpreter phone, because they deserve it. Because it's their health. They need to talk to me through an interpreter. I'm not gonna Google Translate and write words and sign, things, because that's not right. And growing up and seeing that with my mother, knowing she didn't speak English and I was her interpreter for everything, really has personally made me a better doctor in that way. It has made me more compassionate and impassioned to help those and really listen to them and take that time, because they were there for 8 hours waiting for an x-ray, or 10 hours. And I spent another 10 minutes with them really explaining why this, that, or the other. So it has been both a gift and a curse in that sense. But I think overall, my being raised the way I was and what was instilled into me by my parents has been nothing but beneficial.
Okay, so the next questions, we have a number of questions in the Q&A. Someone asked, do you have some tricks to finish medical school fast? My major is biology and I'm in community college and I'm just start taking pre-medical courses.
Well, can you see me? Or is it just my screen?
No, we can see you.
I can see your screen.
Oh, okay, great. You can see me too, right? I'm looking, I want to make sure. Okay. Yeah, so the quickest way, I guess, is to be a science major. I mean, there is no quick way about it, because you have to take the courses, right? You have to do a certain, bio, you have to do chem, you have to do physics. So there's no way cheating through those. There's no way to do, physics 1, 2, 3, 4 all in one semester, right? So there is a time commitment. There's nothing that's gonna get you there a year earlier. Now, other than killing yourself and taking 40 units, a semester and things like that. So the best way to do it, and I don't tell everybody this, but is to be a science major and to match all your prereqs for med school with your prereqs for your major, right? That's why a lot of doctors are science majors. It just makes sense, because the classes you take are the same, so you don't have to double up. But if you're like, I love English and I want to be an English major, well, you can, and then take science courses, right? It's going to take you longer. So by doing a science major, you're going to have a quicker time in that sense of getting through everything. But overall, there's no cheating out of it. And I'm not saying you're trying to. I'm just saying it's that time commitment. And I promise you, you put your head down, you close your eyes. 5 years from now, you're gonna be like, oh shit, it's 5 years. It will go by fast. I promise.
It's a marathon, not a sprint. We have an event on June 11th that it's basically a step-by-step guide from community college to medical school, the classes you need to take, the steps you need to take. And that's a 1 hour detail with slides and stuff that you should come to that. Yeah, that's way more detail. Dr. Rahimi went to community college last century, so.
Oh, no, it's this century. Come on, this century.
I'm just kidding. It's been a while.
I'm getting old.
We have one more question, and then we'll let you go. Min, do you want to ask that question?
Oh, yes, sure. So the last question is, what is the specialty you think you'll go in when you apply for med school? And is it emergency medicine in the first place?
So great question. Everybody thinks they're going to be something when they go into their first year of med school, right? They're like, I'm going to be a plastic surgeon, I'm going to be an anesthesiologist, I'm going to be this, that. It doesn't matter because it's going to change. I think it's like the percentage is like 90-something% of people who have an idea of what they're going to do going into medical school, like change that. And the reason is you actually, once you become a third year and you actually in the hospital, you're like, oh my gosh, babies suck. They cry all the time. I thought I wanted to be a pediatrician because they're so cute, but now in the hospital, they're not cute. All they do is scream and cry and poop. I thought I wanted to be a pediatrician. Now I don't want to be a pediatrician. Well, you didn't know that until you actually started doing that rotation, right? So that's the big, you want to come in with an open mind, a clean slate. We obviously you might want to know, you think you might know what you want to do, which is fine. You don't have to say, oh, I try to shut my brain down, but you want to come in with an open mind and say, if I like, you might like delivering babies and doing some like minor surgeries and seeing people for their blood pressure, then you want to be a family practice doctor, right? In the community or something. Or it just really depends on what you end up liking to do in during your rotations. It's very surprising. My group of friends in med school, we all went into different things that I was not expecting some of them to go into, and then during their rotations, it really took a shining. One of my best friends became an OB. We had no idea he was going to like be an OB, but he is an OB guy, and it's great. But it was just one of those things. He fell in love with it during his third year. Totally took us all for surprise. He's a wonderful OB in Oregon now. So it is one of those, keep an open mind. You're going to change your profession in medical school at least a dozen times. I want to do this, I want to do that, I want to be a surgeon, I want to do this. And that's totally fine because there's so much opportunity and so much opportunity to shadow in those areas to see what you really like to do anyway. So it's not an end all when you get in there and say, I'm going to be this, and you just work that way, because you're working to graduate, right? You're working to get good grades. So all of that other stuff falls into place.
Alrighty, my friend. I don't think we have any more questions, and we're gonna let you go because it's your day off and your wife has other things for you to do.
I can hear her.